Welcome to Cincinnati Sessions, a production of University of Cincinnati Internal Medicine Residency. I'm your host, Drew Kelleher. Today's topic is steroid induced hyperglycemia. During the COVID pandemic, I imagine that most of you have seen dexamethasone used a couple of times. I also imagine that you've seen a few patients with hyperglycemia, but why do steroids cause hyperglycemia? A quick disclaimer, steroids work on nearly every organ in the body, and the most honest answer is that it's multifactorial. But I hope that this PowerPoint will outline the most predominant mechanism for why this is caused. Let's review a case. A 61-year-old man with a past medical history of diabetes, hyperlipidemia, hypertension, and obesity present to the ED with shortness of breath, found to be slightly hypoxic, requiring 2 liters nasal cannula. A week ago, his PCP diagnosed him with COVID after he was complaining of fevers, body aches, and sinus congestion. His most recent hemoglobin A1C was 8.7, and he takes metformin 1,000 milligrams twice daily. He gets admitted to the hospital, and you decide to put him on dexamethasone, and you decide 6 milligrams daily. How will this patient's insulin regimen differ from a typical patient's insulin regimen? Pause the video and try to answer this question for yourself. If you are next to someone, present this case to them and discuss it together. After you try to answer the question, resume the video. Let's review some physiology. After we eat, insulin is released from the beta cells in the pancreas. GLUT4 is a transporter molecule found primarily in muscle cells and adipose tissue, which is used to transport glucose from outside the cell to inside the cell. GLUT4, unlike other facilitative GLUTs, is primarily stored within intracellular vesicles in the unstimulated state. When insulin binds its receptors, GLUT4 is then quickly transported to the plasma membrane, and it becomes available for use, causing glucose absorption. This transport step is rate limiting for glucose uptake into fat and muscle under most conditions. This is important. Skeletal muscle is responsible for 70 to 80% of our postprandial glucose storage and is the body's largest reservoir for glycogen in the body. Now let's review some pathophysiology. Remember that muscle stores glucose after eating through the GLUT4 transporter. Steroids interfere with the signaling cascades that lead to GLUT4 being on the cell membrane. So this decreases insulin-stimulated glucose uptake within muscles and reduces glycogen synthesis. Therefore, glucose remains in the bloodstream, which we measure as hyperglycemia. Lastly, a note about pharmacokinetics. Prednisone is an intermediate-acting glucocorticoid. It reaches its peak effect around 2 to 6 hours, and its half-life is also around 2 to 6 hours. On the other hand, dexamethasone is a long-acting glucocorticoid with a half-life of about 36 to 72 hours. Therefore, after a 10-day course of dexamethasone, steroids will still be in their system for several days. So let's answer the question that we asked at the beginning. Most inpatient glucose management guidelines for sub-Q insulin therapy recommend that 50% of the insulin total daily dose be administered as basal insulin and that 50% be administered as 3 equally divided doses of nutritional or prandial insulin. Notably, the Endocrine Society and the ADA in their most recent guidelines recommend the use of continuous insulin infusions in patients who receive high-dose glucocorticoids and develop severe hyperglycemia, a treatment that can easily be implemented in the ICU, but not so much in the general wards. However, patients who receive steroids develop significant postprandial hyperglycemia due to decreased insulin-mediated glucose uptake in the peripheral tissues, leading diabetes experts to suggest that patients need to be treated with more nutritional or prandial insulin rather than basal insulin. So the simple answer to our question is we increase the mealtime insulin, as steroids tend to cause more postprandial hyperglycemia rather than the basal insulin. So questions for reflection. What is the function of the GLUT4 transporter? 2. Based on the pathophysiology of steroid-induced hyperglycemia, how will this change if the patient has type 1 diabetes versus type 2 diabetes? 3. After the patient has finished his course of dexamethasone, how long will you expect his postprandial hyperglycemia to last? Pause the video and try to answer these questions alone or with a friend. Try to say the answers out loud, and if you have to, Rewind the video to find the answers. Thank you for watching Cincinnati sessions on steroid-induced hyperglycemia. Please be sure to check out other videos in this series.